Hi everyone, my name is Jeff Belkora. I'm with the University of California, San Francisco. And I want to present today on an innovative staffing model for supporting patients in being informed and involved in their treatment decisions. And I do want to acknowledge some funding sources. We don't have any commercial conflicts of interest to disclose, but the Informed Medical Decisions Foundation has been funding our project since 2004 as a demonstration project. Of course, I also want to thank the organizers of the conference today, the Institute of Medicine, and the sponsors, the Moore Foundation and Blue Shield. And of course, the conference staff, thank you for helping us attend here. And I say us because I brought two students. So Ekene and Margot are actually going to do the bulk of the presentation. But I do want to just introduce what we're talking about a little bit to say that we did start with a needs assessment about 10 years ago in the area of breast cancer, where I was lucky to have a partner, Dr. Laura Esserman, who is a real champion, along with her other colleagues at the UCSF Breast Care Center, real champion of patient-centered care, and they felt like they could be doing more to address particular patient needs. And we focused in on what patients told us in their own words, was that during that time when they had a diagnosis, but they were waiting for an appointment with a specialist, that was a time of real information anxiety, that they were conflicted, they were bombarded with either conflicting information or too much information, or they didn't have enough good information. At the same time, they would be lying in bed at night thinking of issues, but then freeze up when they got to the doctor's appointment and forget to ask those very issues that have been keeping them awake at night. And if the doctor did happen to address the questions that they had been concerned about, the information went in one ear and out the other. So we were happy to learn, of course, that there were evidence-based strategies to address these information and communication needs, specifically many randomized controlled trials showing the effectiveness of decision aids in orienting patients to an unfamiliar condition in terms of knowledge and other measures. But there were also other communication aids, I call them, that would help people with the other concerns, such as making a list of questions. Very simple act of writing things down and bringing that list into the appointment and referring to it helps people remember, not surprisingly, what they wanted to ask about. As well as after-visit summaries and recordings, which help people review the information kind of in a more relaxed setting and benefit from repetition. So we turned our attention to really asking, who can deliver these decision and communication aids in our clinic? And what we found was that we tried initially to get existing staff, for example, schedulers, to really facilitate the use of these tools, but they were already overloaded with their existing tasks. So we then had, and it was really Laura Esserman who said, well, we have these pre-medical interns who are in our program doing, they're working as program and research assistants on other tasks. But what about if we had them set aside a day each week to accompany patients on their journey and facilitate the use of decision and communication aids? And so Ekene is today one of these pre-medical interns. While she's coming up here, I wonder if you could get to your packet and look on the right side and find the next to last piece of paper. And I understand for those of you on the web that this handout is also available to you electronically. But if you can find the one that says question list, it's handout for Patient Support Corps presentation, that's us. So it's in my packet, it was the next to last piece of paper on the right side. And Ekene is going to tell you a little bit more about the program.
Thank you, Jeff. So hello, my name is Ekene. I am one of the 10 pre-medical interns at the UCSF Breast Care Center, and I am the Tuesday morning intern, which means that I call all the newly diagnosed breast cancer patients coming in with Tuesday morning appointments. So to demonstrate a little bit about our process, I'm going to tell you about my patient, Ella. Okay? So when Ella makes her appointment at the breast care center, she shows up on my call list. So I call her, and I offer our services to her, and she accepts. So what does that service look like? Well, bam. Step one of this process is I have to determine what is the correct decision aid for her. So during the offering call, we determined that she needs the decision aid on ductal carcinoma in situ, which is precancer, stage 0 cancer. And that looks like this. It's a booklet, and it comes with a DVD. So I put that in the mail for her, and then in about 3 days, I call her. And we spend about 30 minutes going over her primary concerns, her major pressing questions, and I get them all down on a piece of paper for her, which is step 2 of the process, and that is what you have in front of you. So is everybody looking at it? So, underneath the situation heading, you can see that one of her major concerns is that she doesn't understand why she needs to have surgery if DCIS is a stage 0 cancer. Under the objective section, you can see that she's also really concerned about working because she's a firefighter, and she's also concerned about how she's going to come out to her kids about her diagnosis. So these are all the questions that are her major concerns, and I would like to say that these are her own words. So I've gotten these words from her using a neutral, non-directive approach in the question listening session, not giving her any of these questions. These are all her questions. So I send these to her, and then I send this also to her doctor. And then about a few days later, I attend her appointment with her. I have my laptop and my recorder in hand. This is what the recorder looks like. And we wait for the doctor to come in. The surgeon walks in, and he has the question list in hand. And he actually uses the question list as the patient agenda for the appointment. So he uses it to guide how the appointment runs. And I sit there and I take notes, and I also record the appointment, which are steps 3 and 4. At the end of the appointment, I produce a CD recording for Ella so that she can go take that home, and her husband, who couldn't make it to the appointment, can listen. And the next day, I also sent her the appointment summary, which is on the back of that handout. And so from all of this, after 4 weeks of time has gone by, we sent a survey to all the patients who have received this service. And in Ella's survey, she says that she really appreciated having someone there to listen to her and to listen for her. And I think that is really what I've taken away from this service, is the ability to listen first and to listen fully. And I truly hope to take that with me as I continue on this path to becoming a doctor. And now to talk a little bit from the perspective of someone down the line, Margot.
So my name is Margot. I'm a first-year medical student at UCSF, and before that, I was a pre-medical intern like Ekene for 2 years at the Breast Care Center. And what Ekene just told you about her patient Ella being very grateful for our service is a very typical reaction. We have years of qualitative and quantitative survey data from our patients that we've published telling us how much they appreciate the service. So here's some representative quotes about the decision aid. One woman said, "This was exactly the material I was looking for all over the web, but having a hard time finding in a consolidated format that made sense." And about the question list, another patient said it was hugely helpful to have my questions prepared beforehand. Finally, about the recording and summary, they were invaluable in filling in parts of the conversation that this patient and her family were finding hard to remember. So we know that our service is working well for our patients, and we have anecdotal evidence from intern alumni like myself that they're using the skills they got as interns in their medical education and further down the line medical practice. So one example of this is a friend of mine named Meredith was telling me she's in medical school and she has a class where they learn how to interview patients. It's her day to interview a patient, and the patient walks in and the first words out of his mouth were, "Do you think I'm going to die?" So as she tells it, she froze up for a second, not really knowing what to say. Then she remembered a Jeffism, one of the phrases that we're taught to use with patients. And so she says to this patient, "What is your understanding of your situation?" That allows them from there to have a whole discussion about his recent diagnosis, how he feels about it, his recent hospital stay. They have a very productive discussion there. And that was the feedback Meredith got from her facilitator and peers who were watching this interaction, that having that sort of opening question in her toolbox allowed that conversation to go so well. And she attributes that to her time in our program, where we use that sort of question all the time. So Jeff and I got curious about do all of our alumni have this experience where they're using the skills they got in our program to this day? So we did a survey this summer of all 47 of our alumni. They're at various stages. 7 of our respondents, we got 21 responses. 7 of them have completed medical school. 8 are currently in medical school, other stages of the process as well. And here's some sort of typical responses we got. One person said, Decision Services, which is our program, helped me actually learn the art of listening through practice, patience, and silence. I learned to silence my own voice and let the content of the patient and the physician guide my own work. That's really echoing what Ekene just said about learning to listen to our patients through our program. We also got a response from someone who's currently a practicing physician saying, now as a doctor, I believe the core values I developed as a pre-medical intern are still there. A non-judgmental attitude, a careful approach to humor, and an avoidance of saying things that I truly can't control, like everything is going to be okay. And what this is getting into is Ekene made reference to our neutral and non-directive style of interviewing our patients. And as pre-medical interns, we're not giving advice to our patients, we're not answering their questions, because we're not qualified to be doing that. And so we're very conscientious about how we talk to patients in this role. And this person is saying that they're taking those skills they learned about conscientious communication forward with them through their medical training and into practice. And so that was very gratifying for us to see that we knew this program was a win for our patients. We now know it's sort of a win for our intern alumni. And Jeff's going to talk about how we can expand it.
Yeah, thanks, Margot. So we do feel fortified in our motivation to expand this program, given the successes we've had with patients, and then also the educational trajectory that we're putting pre-medical students on. There is a question about, these are paid staff interns. So how do we expand this program and keep things somewhat affordable? We'd like to get beyond the breast care center to other clinics. We'd like to get beyond our institution. And so we looked across the Bay. At UCSF, we don't have an undergraduate patient population, but we realized across the Bay in Berkeley, there's 30,000 undergraduates, and about 3,000 of them at any given time are pre-medical students. So we decided that we would look to a volunteer workforce to extend our coaching capacity, again, moving out from the breast care center into other clinics. And actually, Lindsay Forbes is here, who was one of the first Berkeley students and is now working at Johns Hopkins. But so our alumni are spreading all over the place. But Lindsay and her peers are coming over now and working in our orthopedics clinic, in the urology clinic, in the spine center, and in head and neck cancer. And that's just in the first year, really, of the program as we've been expanding. So we feel good about the possibility of expanding this into what we're calling the Patient Support Corps, using kind of the metaphor of a service learning program. The students, or possibly other volunteers, get academic credit or get other benefits. And the mission really is to provide this workforce as coaches for patients and families so that the patients and families can be as informed and involved as they want to be. So this has been working well, and in fact, the program has now been replicated at Dartmouth. And at Dartmouth, they've said, well, let's not just use undergraduates, let's also use public health students, so MPH candidates, and medical students. So we're quite optimistic about the potential for this program to expand, and of course, in the days of telemedicine, it would be possible to deliver these kinds of services, at least in part, remotely, so that I work in rural areas in Northern California as well, and we definitely want to be able to reach people and help them with question listing, and even attend their appointment if necessary by speakerphone and take notes for them and do all those sorts of things. It's all possible now, I think, with technology. But the value proposition overall for the Patient Support Corps, I have high hopes that we can make this sustainable in the sense that clinics should be willing to put some money on the table to support the administration, the training and supervision of the volunteer workforce. And also the academic institutions, colleges and such, should also be willing to put some money on the table, I hope, because they're getting tuition and they should be diverting some of that for this kind of service learning experience. So we're cautiously optimistic that this can, in fact, scale and be sustainable because of these kinds of win-win benefits ultimately for patients, but then also for students. So we're right now in the very beginning of what we hope will be a 3-year startup period. recruiting other members to the network. We feel like we have UCSF on the West Coast, Dartmouth on the East Coast. Let's fill in the rest of the country now. And we want to refine our service and product offerings, refine the business model. And frankly, you know, we're looking for funding and other partners. So this seems like a good audience for me to do a little bit of networking in. And certainly, I told I consider myself a mentor for Ekene and Margot, and I told them that when we come on a trip like this, we're not allowed to have dinner together. So we're going to be looking for ways to network with you all, and please come find us and talk to us. Of course, we'll also be on the panel now. So thank you very much, and thanks again to Margot and Ekene for coming out.